Good afternoon, and welcome to Quality Interactions live discussion, The Path Ahead, Equity in COVID-19. I am delighted to have you join us today for a discussion on one of the most pressing issues that we're all talking about, which is vaccinations, particularly the COVID vaccination. I am here with my colleague and friend, Dr. Joseph Betancourt, who is Vice President and Chief Health, Equity, and Inclusion Officer at Mass General Hospital. He's also the co-founder of Quality Interactions. And so we're just going to hit it at the top and ask, where are we today? Where are the numbers going and what did they tell us?
Great. Thank you, Michelle. Nice to see everyone again. And of course, the news is not good, and we're heading into the second surge here. And I would say again, I always try to caveat this by saying, when I say we, I'm going to speak a bit about Massachusetts. Clearly, the country is in different places in different paces. And so some of you who are listening, I mean, you are in the midst in perhaps a surge that was worse than ours in Massachusetts, in March through May. We know that many states are really struggling right now, but here's what we know, I think, at the national level. Across the country, cases are, positivity is increasing. There's increasing community spread of COVID. There's no doubt that policies have played a role as it relates to the spread and how state and local governments have managed their reopening and their policies around mitigation, particularly mask wearing and other particular aspects of mitigation, has played a role in where the surge is highest and worst. The demographics, I'd say in certain parts of the country, certainly where we are, still tend to be younger people impacted. We went from kind of 0, 18, 18 to 29, now we're 18 to 29, 18 to 40. But again, I would, anybody could pull up their local numbers to get which demographic is growing, but that's the demographic that's growing for us. The reason why I think that's important is because your messaging should be tailored to the demographic, and the public health messaging, I think, is critical there. A couple of other things I'd say, I definitely worry that this is different, and I'm going to use our Massachusetts as an example. We worry that this is worse now because in March we shut everything down. No place has shut everything down right now, right? And in March and April, we cleared the hospital out. All hospitals are still dealing with a lot of pent-up demand from the kind of first surge in many markets around the country. So, for example, our hospital, Mass General, is really, really bursting at the seams with numbers now, I think, upwards of 60 patients with COVID admitted. We hit a peak of around 350 during the surge, but we had been mostly muddling along in the 20s for much of post pandemic. So I think that's this is leading to a lot of capacity issues that I think are problematic, and we're seeing this around the country. I'd say that also burnout is a big issue. Many people are really burnt out, and now if you had a little break and you're getting back into this, or if you weren't hit and you're getting into it and you're in the fire, burnout's a problem. We are better certainly around PPE. We are better in many markets, not all, around ventilators, but capacity continues to be an issue, I'd say. A couple of other things, we do have some more treatments available to us from Remdesivir. We definitely have the experience proning, getting people on their stomachs, I think, has been helpful for us. We have another therapeutic, which is the monoclonal antibodies. That is a scarce resource. So we're trying to figure out equitable ways to get that rolling. But, if we look back at history, again, we could have predicted this. The data from the pandemic, the Spanish flu in the early 1900s, similarly had a big peak in the spring and then a much bigger peak. And I'll just tell you, it just feels worse now to me. And it feels worse now because I think everybody was a lot more scared about this in March. And I think, a couple of things have happened. Number one, we've reopened. I think we've relaxed. We have fatigue. And so, and I don't think that fear is there perhaps as much as it was the fear of the uncertainty, because we know more. And, a lot of us know people who have recovered, and there is cases of people who have done poorly. but it's a story that tells itself in different ways across the country. But in general, the story is quite similar. And as we should expect, this continues to and will continue to impact all the things we've talked about, vulnerable populations, and that perfect storm that we've alluded to time in and time out in our discussions.
Indeed. Well, that is sobering. And we also got some good news this week.
We did. I think two important pieces of very great news. So we have two vaccines at our disposal now, soon to be at our disposal. And let me just spec out what we know, and it's important for us to understand this. Certainly, we have Pfizer and Moderna, who both have really reached almost the end of phase 3 with their vaccines, and they're ready. The efficacy, meaning how well they generate immune response, is excellent, upwards of 95%. I'll tell you that in our best year with the flu vaccine, it could be 60 to 70%. So this is 95%. It makes sense because the flu vaccine, we are, and I'll talk more about this in a bit, but the flu vaccine we create it every year, and we're trying to predict what flu viruses, influenza viruses will be coming that fall, and we grab them and we make a vaccine out of them. And if we're good, we predict it a lot. If we're bad, sometimes our efficacy and for the flu vaccine has been as low as 50%. We know COVID, and COVID, thank God, hasn't mutated that much. And so the efficacy, because we know exactly what it is, the efficacy has been upwards of 95%, which is phenomenal. They are both two-dose vaccines separated by, I think, a couple of weeks or so. The difference between them is that the Pfizer vaccine needs to be refrigerated at a much colder temperature. So that creates some storage issues that need to be kind of dealt with. Nevertheless, there are plenty of settings where that will work. There's other more mobile settings, for example, where you want to go into communities and rural areas where that may work less well. The side effects profile are actually quite good. It's just 1 day of, kind of maybe some headaches, some myalgias, muscle aches. I think the challenging thing here for that is that if we give somebody the vaccine and they're a healthcare worker, they may not be able to go to work for a day or two because those symptoms might mimic COVID. And so it's probably going to be get the vaccine, get a day off. That we're trying to work those things out. The idea is that 20 million doses will be available by year end. The National Academies of Medicine has put together a triage system that's very kind of stepwise on, and I think all organizations are following what that triage system looks like. And so there's a pattern there. I want to say one thing which I think is important, and this is going to lead into our next discussion, which is the fundamental difference about this vaccine versus the flu vaccine or any vaccines that we've done. In the flu vaccine, to develop the flu vaccine, what we end up doing is we end up grabbing those viruses, capturing those viruses that we anticipate are coming in the fall, taking them, growing them in eggs, right? Destroying them, so it's no longer virus, taking the proteins and then putting them into vaccine. That is a very, very long process to do. You have to grow, you have to destroy, you have to then build a vaccine. It takes a long time. So the big worry with this period was, boy, if we use those technologies, man, we won't have a vaccine forever and a day. It takes the process point and to create as much that we need would be problematic. So what we have here is what we call an mRNA vaccine. So what does that mean? It's fundamentally different. What that means is that the way a virus gets into the body, and what it does is it sends messenger RNA to get into cells. RNA is a genetic material. It's a message that then encodes for the creation of more virus. So virus comes in, it basically sends these messengers. They go into a normal body cell, and the body cell actually becomes the factory for making more virus. And the body's immune system gets so far behind because this thing moves so fast, right? So that's the way a virus works. We scientists are leveraging that same technology, but in a different way. So what this vaccine will do, this new vaccine will not give you the surface proteins, right, like the flu vaccine does, where we try to identify them. It will not be a weakened virus, which we have in some other vaccines, which you take the virus, you debilitate it enough so that it can't infect you, but your body can create an immune response. This vaccine takes the messenger RNA but clips it. It just gives you the vaccine so that the messenger, you're just getting a messenger in there, no virus. Messenger comes into your body, goes into a muscle cell in your arm, and it goes into the muscle cell and it makes the muscle cell make just the wall proteins of the virus, not the virus itself. So it takes that same lethal approach that the virus uses, but it doesn't. It's like you have a blueprint, and I got here. I'm going to inject your cell with the blueprint for the whole virus. No. In the vaccine, I'm going to inject your cell with the blueprint that stops just at the wall. So it's not a live thing. It's just the wall proteins. So I get that. It goes into my muscle cell. My muscle cell makes wall proteins, spits them out. They're just random proteins. My body creates an immune response to that. So you get the difference of differences as opposed to kind of me guessing and giving you some proteins that took me a year to make. This is incredible. We're using this mRNA to use our own bodies to make those same wall proteins that I would give you with the flu virus for your body to make them, and your body triggers an immune response against them. So it's fascinating science. It allows us to develop it a lot quicker, and it's been incredibly effective.
That's
So I think that's the part that people really need to understand. Yeah.
Do we have a sense of how long the vaccine will be effective for, or is it too early?
Yeah, it's kind of. I think the studies show that it's going to give you pretty strong immunity, particularly with this in the 2-dose. The second dose gives you strong immunity. We're going to need to learn more. This will get us out of this period now. Whether we need to do another booster in a year, we'll have to see. But this will at least give us enough immunity for a year. And I have to admit, I don't know all the exact science on what the immunity projections are. There still is a sense that if you got the infection, this mimics immunity pretty well. But if you got the infection pretty bad, you're gonna have pretty good immunity for a long time too. So, yeah.
Well, this is awfully promising. But what are the challenges in meeting the needs of diverse patient populations? It's a lot of out there.
Yeah, there is, and so and there are three big ones, and there's three ones we've discussed, but there's one caveat that I want to make. So we've talked about mistrust, and that's still there. There's still a sense that I'm going to wait till other people get it. So there's that concern, and I'm not going to get it all. There's so I bucket the first of the three is kind of mistrust and cultural factors, which is culturally, if you said no quiero vacuna, I haven't wanted a vaccine, I don't want this one. So those two things still exist. We've dealt with them with vaccines, forever. And I think the only good news, there's two good news pieces here. I have had more of my patients who've never wanted to get the flu shot this year than ever before, right? They've gotten the message, they kind of got a little bit of like, oh man, I should get this. So, and we also saw that with the H1N1 vaccine, where there's almost like this weird thing that if there's not enough available, like, wait, I want to make sure I get that, right? So we hope that could, to some degree, address this. But that mistrust and cultural factors will again play a role. So anything we do will need to address that. But the asterisk I want to put around the mistrust and cultural factors, what I just explained to you, in my mind, is going to be extra scary for our community. It's going to be extra scary if we explain it to that level of detail. And this is something I'm trying to reconcile in my mind, how far down I want to go on that level of detail, because I worry that if we tell people we're injecting genetic material into you so that your cells can do something, I'm worried about the extra fear that's going to create, the conspiracy theories that's going to create around I'm injecting DNA into. What is this going to be? This is not this isn't as clean and dirty as the flu vaccine where we're just going to put surface proteins in you and it's just stuff floating around. We're using your body to make it. We're giving you genetic messenger. And I got to just be blunt. I don't have an answer on how I'm going to manage this, because at the same time, I want to be transparent. I really know that that's going to raise alarms when people say, wait, what are you going to do? What? Intimate genetic material? Like, are you going to alter me? You know, you
Yeah.
know all the different ways in which that's going to go. So there's that. The second is that for diverse populations, that the National Academies of Medicine, their recommendations, I think you and I have talked about this already, is healthcare workers, frontline workers, and populations that have been disproportionately impacted. So for the first time ever, in my view, as it relates to technology, therapeutics, all the stuff that we talked about, where there is routinely a diffusion lag of years
Right.
for people people in vulnerable communities to get the latest and the greatest. Now I'm going to knock on your door and say, hey, guess what, Michelle? You've never got anything first, but today's your lucky day, and I have this vaccine, and it's genetic material, and we're just getting rolling. But you could understand that you have communities here that this really breaks from history, breaks from tradition, and you and I are going to have to look people in the eye and say, yeah, it's okay. This is it. I'm trying hard. I want you to get it first. This is a good thing. And they're going to be like, wait a minute, don't tell. I've been never getting anything first, and
Right.
now I'm getting stuff first. So I think that's the second. If we get past the kind of language, trust, cultural factors, if we get past this kind of discomfort of getting it first, the next big barrier is, how do we get it to people in vulnerable communities? Just the deployment of vulnerable communities. We've talked about immigration issues, people worried about issues related to public charge. We've talked about language barriers, like all that stuff is going to play a role just in how we physically get it to you and deploy it to you. So those three things, I think, form a foundation for how we need to begin to think about, not in 2 weeks, like yesterday, about how we're going to do these things. Now, I'll say one last thing, just related to vaccines. There is another there's going to be more vaccines. There's going to be a bunch more. The next one that's on deck is Janssen, AstraZeneca, right? And I guess Pfizer and Moderna actually did pretty well with their diversity in clinical trials, better than they've ever done. People are still having it home. They're saying, yeah, the diversity is good, but it doesn't represent the amount of people who are impacted. I get it, but
Right.
yes, so it's, I'm
One
saying
step at a time.
one step at a time. Like, we're at least at population parity. Like, that's that's good, and yes, so they did a good job there. But my worry is Janssen and AstraZeneca. These are the people who are still in clinical trials. I'm trying to do diversity in clinical trials right now with Janssen. How am I going to go into a vulnerable community and say, hey, do you want to get in a clinical trial for this vaccine? They're going to be like, why the hell am I going to do that? You got two that are ready already. Like, why am I going to do a trial, right? So aside from that, the Janssen vaccine, interestingly, is one dose. So from a deployment standpoint, that could be promising. But the net here is that Pfizer is going to use half of its supply globally, half here. We are going to need a lot of different vaccines. And then you could also imagine that if the science starts to show, hey, Moderna's has less side effects, and boy, people are going to start saying, no, wait, of those 10, I want this one.
Right.
Or vulnerable communities will be like, yeah, I'm getting the vaccine, but I'm getting the crappy one. So I'm just kind of putting out more things for consideration. But I think those are some of the things that need to be given thought right now as we're considering this. Yeah.
So I know that we've learned a lot of lessons from the first wave around communications for COVID. How do you think we've got this new set of challenges that you just laid out so eloquently. How do we address these?
Yeah, a lot of this. So again, bringing forth equity in all efforts and cross-cultural communication in everything we do. Take the time to be discerning and to really consider the ways in which everything I've shared with you, you can counteract. So let's break it into three areas that address those concerns. From a messaging standpoint, again, we need to start simple. What is a vaccine? How does it work? The basics. We need to do this nonstop. We cannot communicate enough and in enough ways, and we do need to leverage trusted messengers, multiple languages. And I would even encourage people online to do local assessments of concerns within your community. For example, I just did a Facebook Live with a local Spanish-speaking newspaper at Boneta the other day, and before I did it, the reporter said, "You know, Dr. Betancourt, we've heard that there's a pastor here in this area who is very well recognized. You know, over 250,000 followers on on social media, Christian evangelical Latino pastor, who is telling people, no matter what you do, do not take the vaccine. Don't take it. Don't take it. Don't take it." And he's also selling some snake oil, right? Say, I have a something that you could take that's going to give you the immunity, that type of thing. So I say that because I need to now take that head on.
Right.
And while we talk about the importance of leveraging faith-based communities to help us, there are times where faith-based communities can hurt us. And so, I give that as an example to say there's no one size fits all. The types of challenges I'm laying out are some global ones. Find out if there are other kind of counterposing forces that you need to address your messaging to and take on yourself. So that local assessment in your community. So all of this around messaging that I've talked about, we need to spell this out carefully. So we are doing that here. We're looking at multicultural media, trusted messengers, not just doctors, teams of people from the community who could speak to this. We're going to do some public demonstrations of people getting their vaccines, to hopefully engender some trust, testimonials. We're looking at all ways to communicate and to give it a steady drumbeat. I'd say number two is, as we think about this deployment strategy, we do need to create a message around why you're getting it first when you never got it first.
Right.
Right. We need to address that. Like,
Right.
we need to take that on. That needs to be part of our messaging. But we've talked about the importance of building trust, and building trust to some degree requires starting with an apology and starting with, I know this has never been the way, but give me a shot, right? That asks for apology, forgiveness, and a shot. So the deployment strategy needs to explain why first. I think that's a critical part of what we need to do to counteract this. And then finally, as we deploy this, as we think about strategies, we really need to think about ways in which we can get this to all people in all places. Mobile is going to be very, very important. Leveraging people from the community to help is going to be very, very important. So all of the things that we've talked about in this whole series around cross-cultural care and equity, hopefully what people will see is there's a pattern here, Michelle, and hopefully this pattern will stick. It's like, oh, again, we're going back to that. Oh, again, we're going back to that. Let us not continue to need to reinvent the wheel every time. Real transformation is building everything I've been talking about, we've been talking about for all these weeks, into standard practice and standard operating procedure, so that this doesn't have we don't need to do special Zoom webinars on this topic, that people have built it in. That's real transformation. So I think those are the three ways in which I think we can work to counteract some of these areas.
Well, there's a lot going on, Joe, and there's a lot more work to do. I think a number of people are pretty nervous about what's going to happen after Thanksgiving. But I just want to thank you for the work that you're doing on the front line and representing the importance of these messages around health disparities and strategies around how to improve our condition. One of the things that we've talked about in the past is the power of using this moment to really disrupt and transform, as you've just described. It would really be a shame if we don't build in the practices that you've described as part of our core work going forward to reduce and hopefully eliminate health disparities in the future.
Yeah, there's no doubt, and I think that's where we do training. I mean, the bottom line is that what training has helped do is socialize people to these things so that they're not new concepts, so that they understand their application, and so they understand their application to clinical practice, policy, emergency preparedness. That's the reason why we've been doing this for all these years, so that it's not just at the bedside. This is kind of doorstep to bedside. And maybe I'll just take 1 minute to just remind everybody about kind of the holidays here. So look, we all want to give thanks. We all want to celebrate, our holidays together. I'm going to look people clear in the eye. I am scared. I am scared in a different way than I was in March, because I feel like this thing is really out there in ways that's almost sneakier, and our response is while it's trying to be good, it's not the shutdowns that we had earlier, which I think, helped us. And so, in so much as, the optimal, in so much as you can, is to just celebrate with your immediate pool of people. It is not safe to assume that your immediate pool of people, if they are out and about in any way, shape, or form, are not bringing the virus into your house. So doing testing, I encourage people to get testing routinely, and even when they're asymptomatic if they need to. And so even if your pod is, you and your 2 kids, like, and your kids are doing anything out there, you just do not know. You cannot assume that even in your pod there's safety. So that's number one. And number two, even if you have kept your pod safe, keep it to your pod. If you want to celebrate with families, celebrate virtually. If you want to expand anything, do it outside, and just do it for a piece of pumpkin pie and social distance, and have it not be that many people. But the single largest spreading mechanism is eating. It's mass down eating close to people. That's what we've seen in hospitals, our clusters. So, that's a real reality here. And so anything you do outside is okay, as long is better, okay? Because I'm rating these. I'm rating from best is keep it to yourself, to all the way to worse, but trying to give people something to mitigate the worst. But anything outside is certainly better, and spread. And when I mean spread, it's while you're eating, because that's when your mask is down. So spreading there. And if and God forbid you need to, and if it's anybody's older, just and vulnerable, please keep them away. And if people need to come inside to use the bathroom or something like that, have a path, have windows open. It's all about ventilation inside. This is about numbers. This virus is aerosolized. It does sit in rooms, and it does like dry winter, if you're in drier areas. So, there's a lot being done around internal ambient environment and how that leads to the virus, being able to hang around longer. So, preferably not indoors, maybe just indoors to use the bathroom. And if you do that, have a clear path, a lot of windows open, a lot of ventilation. But really, those are the parting thoughts that I leave people with. Because, what we've seen in Canada post Thanksgiving with these huge peaks, I mean, our system is not going to have the capacity to deal with another, extra surge post the holiday. So I hope I didn't take too much time, but hope that was helpful.
That was a great way for us to conclude our conversation, Joe. Thanks so much for that sage advice. And thank all of you for joining us today for the live discussion. Have a great day.
Thank you. Be safe, everyone. Enjoy the holidays.